Good morning. Welcome to Grand Round. In honor of our Rainbow Babies talk, apparently Janie made rainbow donuts in the back. Today's speakers are Jacinda Hayes. Dr. Hayes is a graduate of BCom Blacksburg. Prior to joining the Carilion residency as part of the inaugural class, she went on to complete a fellowship in hospice and palliative medicine and currently serves as the director of nursery and the NAS program. Ms. Sharon Parker graduated Radford with a BSN in nursing and currently serves as a manager of the Carilion Clinic's hospice program and has served in the past as a perinatal outreach educator. Thank you.
Good morning. Can y'all hear me okay? All right. Thank you for coming, and Sharon and I are very happy to be here. First, does anyone have any idea what a rainbow baby is? Anyone Googled this? When you hear rainbow baby, what do you think about? So I figured someone would say that, the Children's Hospital in Ohio. That's a great answer, but that's definitely not why I'm here this morning. So anyone else? Go ahead. Excellent. So a rainbow baby is a baby that's born after a loss. So after mom's had a loss, and then her next healthy living baby is a rainbow baby. So I have a confession to make. I did not advertise that this was going to be a loss talk, and I did that on purpose because I wanted people to come, okay? But we're going to try to make this upbeat and happy, and I hope you guys learn a lot this morning, okay? So rainbow babies and blue moms, how can we help families integrate perinatal or infant loss? Because as pediatricians, we're seeing that rainbow baby, or we're working with the mom of other siblings who's had a loss. Sharon and I are here today as part of the Carilion Share Group. How many of y'all have heard of Carilion Share Group? Excellent. There's a few of you. Okay, so we're going to talk about that share program, but that's why we are here today. So we're going to review terms associated with perinatal and infant loss. Sharon's going to go through the emotional impact a loss has on a family and also discuss the stages of grief mom and family members may experience. And then at the end, we're going to talk about techniques we can utilize as pediatricians when working with these families later. So what are the technical definitions, the technical terms? So a miscarriage is a pregnancy loss before 20 weeks. This occurs in 1 of 5 pregnancies. So this is very common. A stillbirth occurs after 20 weeks, and the fetal weight technically needs to be greater than 350 grams. And this happens in 1 out of 100 deliveries. Newborn death is a baby that's been born but dies within the first 28 days of life. This happens in 1 out of 110 births. And then infant death is 29 days to 1 year old. These are just some pictures of what perinatal and infant loss looks like. So let's bring this, how is this applicable to us? First of all, in the state of Virginia, but then in our area here in Southwest Virginia. So the next slides that I'm going to go through are data from the Virginia Department of Health. This was emailed to me like a month ago. I have all this electronically if any of you want a copy. So these are our stats, okay? So from the years 2014 to 2016, 652 babies were born and then died in the state of Virginia. 1,313 died of natural causes, and then 339 died of non-natural causes. And we'll talk about the difference between those two. 54% of the natural causes actually died before they turned officially 24 hours old. And then the leading cause of natural death for neonates less than 1 month old were conditions that started in the perinatal or even in utero. So things we might have known about prenatally, or then things that occurred right around delivery. And then after 1 month old, congenital malformations, chromosomal abnormalities, those reasons were the leading cause of natural infant death. And then from ages 1 to 6 months, for natural causes, that infectious disease, disorders of the circulatory system, and then disorders of the respiratory system. So moving from natural to non-natural causes, 87% of those 339 were sleep-related. So, and of those, that's a large percentage, right? And we're going to talk more about that. 27% of those sleep-related deaths, the caregivers had a history of substance misuse, and 22% of those, the caregiver had a mental health diagnosis.
Were those exclusive, mutually exclusive, or are those?
No, some of those could be overlapping. Great question, thank you. So for the sleep-related deaths, you can see the percentages here, and these can also be overlapping, but sleeping with soft bedding, sleeping on an inappropriate surface, co-sleeping or bed sharing, and then secondhand smoke exposure. And then of non-natural causes, there were 23 deaths due to homicide within this 2-year period. And of these 23, the perpetrator was a biological parent in 65%. And then when it came to motor vehicle accidents, that caused 3 infant deaths within that 2-year period between 2014 and 2016.
Tell me, what's the Virginia death rate for adults in the 2-year time period? Is it actually a 3-year time period or a 2-year time period?
It should be, I'm sorry, it's 3 years, 2014, 2015, 2016. Thank you. I have no idea what the adult death rate is.
The adult homicide rate in Virginia, or how many adults are killed. I mean, 23 seems like a lot of deaths due to homicide in a 3-year time frame.
Really? I'm surprised it's so low.
Well, that's who they confirmed were killed. It doesn't include the ones who probably were and were sleeping on a soft surface. But I just, seems a lot.
Oh, go ahead. Are you sure?
No,
I don't know anything about adult data. I'm very sorry. I cannot answer your question.
That's why I wasn't asking the general population.
So here in our region of the state, in Southwest Virginia, since 2013, before the 2014 and 2016 data was published, when it came to non-natural infant deaths, that escalated by 131%. And when you look at the other regions of the state, our state had the largest increase when it came to those non-natural deaths. These are the areas that when they say we're in Southwest Virginia, I know this is a busy slide, but when they say Southwest Virginia, these are the cities and counties that are included in that. So SIDS, I feel like I have to go ahead and talk about this because I know there's sometimes with the terminology it's confusing. So sudden infant death syndrome, infant less than 1 year old that we do not have an explanation for after there's been a full investigation. So we've done an autopsy, examined the death scene, and reviewed the clinical history. So, and SIDS deaths are considered natural, not non-natural. And between the years, the 3-year period, 2014 and 2016, there were 6 SIDS deaths in Virginia. I'm kind of going off on a rabbit trail, but we're here at Pediatric Grand Rounds, and Sharon's going to help get us back on the perinatal loss. But with those statistics, I feel like we have to talk about what we're doing for safe sleep education here at Carilion. And in the newborn nursery, on mother-baby, what we're doing is after mom delivers, she comes down from labor and delivery, she comes down to mother-baby. Every mom has to watch a safe sleep video on the Get Well Network, and after she watches it, she is supposed to click yes or no, I understand what I just watched. It's a 90-second video. Actually, I believe Vanessa Hedge is in the video. She is part of that. But it's 90 seconds, so it's not very long. They talk about what a safe sleep environment looks like. And then they have to click yes or no, I will follow these guidelines here in the hospital. And then throughout the stay, if we see a baby that's in an unsafe sleep environment while they're in mom's room, we do education and remind her of what a safe sleep environment looks like. They also get a flyer about safe sleep in their welcome packet. All right, Sharon is now going to get us back on track with perinatal loss and talking about the phases of grief. So let me change this over to her, and then I will be back to talk after she does her part.
So we laughed. I said I've got several faux pockets. I need a real pocket so I can put this mic on. So when we talk about perinatal loss, infant loss, so forth, and Jacinda, I may need you to help me find just like a little clip here. It needs to be. There are a number of terms that we use, and we often use these interchangeably, and in so doing, the meaning, can get lost. And I just want to break this down, simplify these terms even a little bit more so. When we think about grief, that's really an internal expression to the loss. And it's those thoughts, feelings, and we realize that it's really best integrated when it's welcomed versus set on a time frame. Those of you who have a few years under your belt like me probably remember in the evening sitting down with the family, having the TV on in the background in the 60s, 70s, Walter Cronkite's voice, and we would hear every day the volume of loss in Vietnam. And in that time frame, there was a survey that was done. The question was, how long does grief last? How long do you think the general public thought grief lasts? A week? A month? Yeah. 2 weeks. And I don't think we've strayed far from that. Think about how many days we have for bereavement leave, 3. And it's get back to work, get into the game, and move on. Mourning, on the other hand, is that outward expression of the grief, and we know that that can vary culturally. It's important for us, though, not to determine someone's level of mourning grief and how they're working through that loss based on what we're comfortable with, what we've associated that with. And then while bereavement is that entire process that's precipitated by the loss, I love this thought in that it is bereaved means to be set apart, to have special needs. And if you yourself have gone through a loss, which we always like to have a disclaimer when we're giving this presentation, when you talk about the incidence of perinatal loss, I'm sure there are those of you who are in the room who have been directly affected by this. And so if this is a trigger for you and you'd like to talk to us afterwards, please feel free to do so. I think the following poem does a nice job in helping us get an idea of grief. Grief is like the ocean. It comes in waves, ebbing and flowing. Sometimes the water is calm, and sometimes it is overwhelming. All we can do is learn to swim. So why is perinatal death so complicated? Well, one thing, it's often sudden and it's unexpected. We often hear a woman say, I was just going to my doctor's office. I got there and couldn't hear the baby's heartbeat. And so here she's going from planning this whole new life, room's painted, a name is chosen, we have clothes, we've had a shower, to we're now planning a funeral. We're picking out caskets instead of cribs. Huge paradigm shift. Also, families are usually, they're younger and experienced with death. You know, I used to say that so easily, and now as I'm giving this lecture in this time frame, it feels like more and more young people are being exposed to death on a regular basis. But are they learning how to process death in a cathartic way? And they may have had very limited exposure to funerals and deaths within their family. And it's the whole mindset that children are not supposed to die before their parents. I work with 70, 80-year-olds all the time, and they will share grief of a child that they've lost in their 50s, 60s. It just shouldn't be that way. And it's been said that when a parent dies, you've lost your past. But when a child dies, you've lost your future. And then just how infant death is defined by society. Here, when a grandmother dies, we know what to do. We'll bake a cake, we'll send a card, we'll go to the funeral. It's natural, we know that. We talk about all that they've achieved in an obituary. When an infant dies, or even more so when there's a perinatal loss in that pregnancy or there's a stillbirth, it can even be a question, was it a baby? And then it becomes the question of, well, did those parents really have a relationship? And how are they grieving? And I think that lends to the awkwardness on our part of knowing what to say and what to do. What's important to note is that grief is not dependent on the length of the pregnancy, whether the pregnancy was planned or whether the pregnancy was wanted. Share a story of a mother who brought her young child, who was about 4 years old, into the hospital. They determined the child had a cardiac issue. Thankfully, it was easily resolved. But the mother was just so distraught. And they realized there's a disconnect here. There's something else going on. So some very astute and kind person partnered her with a counselor who sat down and spoke with her. And this mother shared the story of how that as a young teen she had become pregnant. Hadn't shared this, had an early miscarriage, went on with life, never talked about it. And it wasn't until her 4-year-old child had this issue that it triggered this loss, that suddenly she now, that grief that had been internal, the thoughts and the feelings gave leads to the mourning, the outward expression that was so important and needed for her to be able to make sense of that. This is one of my favorite slides that we have, and that is grief is experienced in relation to the significance of the attachment. And in this day and age where we can find out earlier when someone is pregnant and we have the means of social media to broadcast that, there are multiple attachments that are happening very early on. And so early pregnancy loss can be incredibly devastating to a woman and her partner. This is a study that was done back in the late 80s. It has been replicated since then. Same type of findings. It's a longitudinal study of women's responses to the loss of their pregnancies with a miscarriage. And what is your perception in this miscarriage? Was it the loss of a baby, or hey, it's 1 in 5? I've even seen 1 in 4 statistics. So is it just a part of life? Notice, overwhelmingly, women see this as the loss of a baby. And I think that's why we want to be very aware of how she's referring to this loss and take her cues in this, how she's perceiving this. So we're aware there are many conceptual models of grief. And it's interesting to note, Alan Wolfeld has come to Roanoke a number of times, and he actually worked very closely with Kubler-Ross and shared that on her deathbed, she never meant for those 5 stages to be independent of one another. She saw them as being interrelated and overlapping. So we're not going to talk about stages as much as we're going to talk about phases of bereavement and how they truly do overlap. And just want to point out, we see 2 weeks here, and then moving beyond that, they're listed as months. This initial phase of shock and numbness, notice this high spike in the first couple of weeks. And note what's going on in this time frame. She's being asked to make decisions, and it's really so much that's going on internally at this point in time, making sense of what's happening. I share the story often when I'm giving this lecture of that this can even happen to practitioners. We can sometimes lose a little touch of reality in the situation, and here's my story. Some of you may remember many years ago when 2 prisoners from Pennsylvania broke out, and they came into Roanoke, and they shot Deputy McCoy, Ricky McCoy. If you come into Roanoke to Salem, you'll see a roadside sign there. Went into a family's home in Salem. They shot the father, they abducted the mother. They took the van, 2 little boys hid up in the closet while all this was transpiring. High-speed chase ensued. Before those 2 convicts were killed, they killed the mother. I came into work that day. We were living with my in-laws periodically. We were building a home, and my father-in-law is a former state trooper, so we had the scanner on. So when I came in that morning, I already knew what had happened. And those of you who recently lived through the WDBJ-7 shootings, and you know that cloud that just descended over this valley, it was a very heavy cloud that day. I came in to care for a woman who had had a stillbirth. And we went through the labor. She gave birth. She held the baby. And they said, okay, Sharon, you need to take the baby down to the morgue. Well, this was way back in the day when we were over at Community Hospital. So what was there at that time? Our forensic department for the whole, for the county district. So I go downstairs, and I open this door, and all I can see is stretchers with bodies. And somebody turned around and said, we don't have time for that. Put it in the cooler. And so I go to the cooler, and I swing open the heavy door, and in that cooler, I mean, it's a very small space, is a stretcher with a man's body, and I knew it was one of the convicts. And so here I am with this baby wrapped in white, essence of innocence, and to me, I'm looking in the face of evil, if you will, and I thought, there's no way I can leave this baby in here. There's just something so wrong with that. And I will tell you, it was one of the hardest things I've ever done. I had to stop and say, wait a minute, this baby's not alive, it's okay. So I'm giving that example that even sometimes for those of us who work in this, it can be difficult to make sense of it all, much more so for this woman who's experiencing it directly. And then having this sense of yearning, searching, making sense of it. What's real? Did this really happen? And anger. Anger at a partner, anger at God, anger at the doctor, anger at everybody. Why did you let this happen? What, and also just a sense of what could I have done differently, and testing what is real. Story of a mom who they had elected to bury their baby. And it was a very cold night, wintry night. And she said, oh my, I've got to get a blanket and put on my baby. Where is she going to put the blanket? On the grave. Now we think rationally, that doesn't make a lot of sense. But from an eternal heart, total sense. And this disorientation And I think often this is where we do see this guilt and this depression. But what I like to point out about this, look where we see the peak, 4 to 6 months. Where is she now? She's back at work. She's trying to move on with life, and she can feel like she is in a fog. And people around her are saying, come on, catch up, let's keep going. And she's thinking, am I going crazy? Shouldn't I be over this? In hospice, we follow individuals for 13 months, and even then we know that it can extend beyond that time frame. And as far as that goes, there are triggers that will happen to us for the rest of our lives that will often happen at the most inopportune times, craziest places. I think Richard Brown would be fine with me sharing this story. He shared it publicly, and you may have heard the story. But after he and his wife had experienced a loss, he was in the grocery store pushing his cart down the cereal aisle, and something about that aisle triggered him, and he said, I had to push my cart to the side and sleep. I was done. Couldn't handle it. We just don't know what those triggers might be. And then with time, we do see this reorganization, that sense of energy, beginning to smile again, and beginning to make not necessarily full sense. And what I will often see women do is something like Stephanie Page Cole did, who experienced stillbirth, taking that experience and turning it into something that she feels is purposeful. This is a phenomenal book, and I recommend it for anyone who's especially experienced a stillbirth. It's poetic. Her art is in here, and the story that she tells is very much from a vantage point that I think as care providers we need to hear. We need to see through their lens of what they're experiencing. I encourage us to think about this too, that prior to getting into this better phase, if we're interacting with this woman, is she eating? Is she sleeping? How is she caring for herself? These are the things that those of us who are at touch points with that woman can be assessing and just bringing up and having that conversation. Wow, it is chaotic, isn't it? And grief is. It is just messy. And it's no one fits all. Grief is just as individual as we are. Now, I don't know if you can see this, so I'm going to read it, okay, because it's so powerful. What do you say? What do you say when a baby dies and someone says, at least you didn't bring it home? What do you say when a baby is stillborn and someone says, at least it never lived? What do you say when a mother of 3 says, think of all the time you'll have? What do you say when so many say, you can always have another? At least you never knew it. You have your whole life ahead of you. What do you say when someone says, nothing? What do you say when someone says, I'm sorry? Say with grateful tears, in warm embrace, thank you. You may look at that and say, nobody would ever say this thing. When I had a perinatal loss 31 years ago, I took some food to my OB/GYN's office. And I said, I just want to thank you all for supporting this process. The doctor looked at me and said, wow, you did this. What are you going to do when you have a real baby? And I realized that person had been trained to care for my physical well-being, but lacked the ability to care for my emotional and mental health. So we know that grief work or mourning requires tremendous effort. People will go back to work doing what they've done before, and they'll come home and they'll go, I'm so tired. You're working. You're processing so many trigger points you don't even realize. And a number of you know Boo Pack. Talked to her last night, one of my beloved friends. And a number of years ago, Boo said, we're going to partner with a master quilter. And we're going to allow women who, they took a book that was Sewing in Tears, that was a garden, sewing in tears and being able to have new life after death. And they said, what if we SEW, sew in tears, and have these women come back and create these lap quilts? And so this particular woman just really became engaged with this process, and she said, come back and you help me like put a border around my quilt? And they said, absolutely. And I just love this because just notice the intensity of this work on her face. And this is her finished product. And I hope that you can see the 3 hearts that are represented in that quilt. She had experienced 3 losses. And she said, I had to finish this quilt because I had to show my mother-in-law that I could finish something that I started. And Heather, who is on the front row, actually cared for this mom. Huge takeaway, grieving is not a process of forgetting, but rather of remembering. What I see in hospice, and I've done lit searches, and I'm not finding what I want to find, but boy, am I finding a lot of anecdotal sharing. Individuals at end of life who have unresolved grief over a perinatal loss, it is coming to the surface. Recently, one of my colleagues shared with me about a gentleman who, as he was dying, he had been married to his wife for 42 years and shared with her that during the war, he had had a relationship with another woman. They had had a child who had died. And it was during these last days on earth, he said, I think about that child every day. I think it's some interesting research that should be done. We know that oftentimes that, especially historically, people have been discouraged from talking about these losses. It wasn't kosher. It wasn't the right thing to do. And it will come out. So now my question to you is, how do we encourage to have these conversations? Yes.
All those graphs, are they the same for fathers?
I think that's a really good question. I think those graphs are not just indicative of perinatal loss. I think that they transcend. I think that they really speak to bereavement in general. Your question is great. Fathers grieve differently. Mothers grieve in the present. More so, fathers grieve over what could have been. You know, they grieve over the missed milestones of taking the child to the game, taking them to fish, or whatever that's going to look like. And I think oftentimes we find fathers more reserved. They feel that they have to be the one helping her through the process. But I think this story that I just shared about this man at end of life, he was processing this internally all this time.
Is everybody doing okay? All right. And I just want to echo that anecdotal evidence with hospice. During my palliative fellowship, this came up a lot as older, elderly patients were on their deathbed. Just they didn't have that closure. So this does affect long term. Is that okay? Thank you. I'm struggling. All right. Okay. And we are, I should have said this at the beginning, we're not singling the pediatric department out. We're giving the same lecture next month to the OB department. Sharon has gone to OB offices, the outpatient offices, and also the outlying ERs because they take care of a lot of these moms. So why don't we talk about this? And let's just get real. It's sad. It's uncomfortable. We don't know what to say. We feel helpless. We went into medicine to heal and help, and we can't, this isn't a quick fix. The other thing is, sometimes we don't have time to have these conversations. If you've got 30-some patients in clinic, this isn't going to be a 2-second conversation. So these are some of the barriers as to why we don't address this. So what are just some simple things you can say? So we're taking care of, we're the doctor for the rainbow baby, the baby that was born after a loss. If we learn a mom has had a loss, if that comes up, I'm so sad this has happened to you. That's just one example. I'm sorry for your loss. This must be so hard for you. And then, how are you doing? How are you doing with all of this? Or sometimes, especially if mom is showing some emotion, you don't have to say anything. You can just sit there and be present. And that is healing in and of itself. And then accepting and validating mom's emotions. You know, letting her have that time to cry and just sitting there and letting her show her emotions. Now, I hate crying. How many of you hate crying? Okay, but if something if you start getting emotional, it's okay to shed a few tears. You're not going to make mom feel worse. You actually might make her feel better, knowing that this is also sad and heartbreaking to hear for you, too. Now, please don't out of control, inconsolable sobbing. That's not helpful, okay? But if you shed a few tears, it's all right. You're not weaker, okay? Actively listening, making eye contact. And actively listening means we're not typing, we're not writing, we're sitting there, we're paying attention, we're engaged in what mom is telling us. So we're seeing this baby in clinic, this rainbow baby. Maybe ask mom if she seems like she wants to talk about it. Well, what was your other baby's name? Did you name your other baby, the baby that you lost? Who do you have as support? Who's supporting you with your loss or with your new baby? And then if she does seem engaged and wants to talk, what hopes and dreams did you have for your other baby? And use the name. If she did name the baby, try to remember and use the name, okay? And then have you memorialized your baby, the baby that was lost? Have they done some ritual or memory making for that baby? These are examples. There's lots of ways yes, I'm sorry.
One of the things that, because infant death can be very sudden and shocking, is actually using D words, death, dying, those kinds of things. You're using loss a lot. So when it's kind of passed and removed,
in terms of using what terms to use, is it better to use loss and lost versus death, dead, dying?
So great question. So yes, and what we'll learn in PALS and what we use and what you use all the time is, I'm sorry your baby has died. I'm sorry your child is dead. Like in the current time, you have to use those words. But this is like we're now the pediatrician for the next child, and we're learning that mom has had a previous loss. So yes, I'm saying loss because it could have just been a miscarriage. It could have been a stillbirth. It could have been an infant death. So do you have anything?
I think it's a great question, Karen, and I think that we have to be realistic because at the time that the baby dies, we need to refer to it as a death, because if we don't, then there will be a question, did my baby really die? And I think outward from that, I take cues from the mom. I really do. But I think in the moment we need to be very clear, which it sounds harsh, but I think we come from a firm love perspective, and
down the road, it will help with her grieving process.
And some things I've read in terms of like taking cues from mom is, I didn't lose my baby. I know exactly where he or she is. And in terms of using names, if you don't know names, genders. It is not it. I saw that on one of your slides. I cringed at that one.
Okay. So what I would like to do now is show you all, if a mom does experience a loss here at Carilion, whether it's a miscarriage, stillbirth, or neonatal or infant death, we're saying the D word a lot. I want you all to know what we do here via the share group, okay? So this has a lot to do with memorializing a loss. So let's say mom delivers at 21 weeks, a stillbirth. She will get this really nice kind of bag, so to speak. We have all different size gowns for babies, so small to large. Let's say maybe it's a term baby that's a stillbirth, so we have bigger gowns, and all colors too, whether it's boy or girl. So I just brought a white one. So we have pink, we have blue. Purple's not so much a good color, as you can imagine. They can get a blanket. Again, we have all different sizes. A lot of these are made and donated to us. We also get a little hat. Again, we have all sizes, all different colors. And they get our share book that they can look through later at home as they're processing, going through the grief. We also have this certificate where we can put handprints, footprints, baby's weight, baby's name, you know, and they could then frame this if they would like. We also offer pictures if parents would like photos taken of their baby, and a certificate of blessing, so if they would like to see one of our chaplains and have the baby baptized, they can do that. And just a lot of other memory making. So we do foot molds, hand molds. This is actually something new we're going to be using and giving to the moms. This is the molding clay to do prints and then put pictures, so like a memory box. So also just little mementos, like this is a little ring, and this can go in a memory box as well. And then this is one of our smallest caskets for a really tiny stillbirth, and then we do have smaller ones, and it comes with a blanket too. So that is ways we can help moms here in the hospital start their grieving process. Other ways that moms, other rituals and memorials they can do. Some moms get tattoos, some have special jewelry made, ceramics, doing a butterfly release, taking pictures, just some different ideas. So if you're run into a mom that is still struggling with her past loss and hasn't done any of these things, you could suggest something like this.
Any fundraising for this, or is this something that has to be purchased?
Oh, the moms don't pay for this.
Do we have like fundraising options that we could maybe have assisted?
We'd love for you to
Yeah,
demonstrate.
just a full 3D. There was a time that we sold, this is all copyrighted, the footprint cards and the memory notes. We intend for you as a caregiver, if you've cared for this family, maybe to write them a note and send it off, because it's very meaningful. But yeah, so we're happy to take questions. Fundraising at this time, we don't need to. We're fairly funded. But it's nice to put it out there, because it's, again, something maybe a family could do in honor of their baby, is to help support the next family.
And many of the blankets and the gowns and even the fabric satchel, individuals in the community make and donate.
Right.
Okies has been a very strong supporter to us, and we've had churches as well that have donated.
Great question, thank you. So moving on, we've already talked about what a rainbow baby is, babies born after a perinatal or infant loss. So as a pediatrician working with this mom after she's had a loss, this next pregnancy and at delivery and in the hospital, she's going to be incredibly anxious, right? That makes sense. During pregnancy or even right after delivery, she may be afraid to bond with the current baby. And it's a protection mechanism. I lost my last baby. I don't want to get too close to this baby. What if I lose this baby too? And then once, next baby's born, healthy, doing fine, well, now parents are struggling with this double guilt. I don't want to forget my previous baby. I loved that baby, but I love this baby too. And so there's just a lot of mixed emotions. Moms and dads go through those feelings. So I'm just going to kind of run through some scenarios, different places we'll be as pediatricians. So in the newborn nursery, paying attention to those G's and P's as you're looking up your new patient, that baby that was just born last night. We got to do the admit note. We got to see the baby. We got to record mom's G's and P's. Okay, well, what about that A piece? Is she a G4, A3? Is she a G2, but her first baby was a stillbirth? So just paying attention to, when we see G1, we're like, okay, this is the first time mom, she's going to need lots of anticipatory guidance, she's going to have lots of questions, she's never done this before. But just because she's a G3 doesn't mean she is experienced, right? Some moms do have elective abortions, and at the time when they make that decision, they feel like that's the right choice for them to make. But later on, they still have regret. They might have some guilt. So just because it was an elective abortion doesn't mean later down the road they don't feel like it was a loss. And then this is the scenario I'm seeing quite a lot in the nursery is if a mom had a previous infant death and she started breastfeeding or pumping, say her baby was in the NICU and died in the NICU, and then she's delivered, term baby, everything's going well, she wants to breastfeed this baby, but every time she puts the baby to the breast or tries to pump, she gets those feelings again of, oh, the last time I did this, my baby died. So some different inpatient scenarios. You're in a delivery room. Let's say it's a scheduled C-section, and she's in the OR on 13. And her previous C-section maybe was twins, and one of the twins passed away or died. I'm sorry, one of the twins, sorry, thank you. One of the twins died, but she's in that same OR, that same environment again. Just thinking about what that mom went through previously. Let's say her mom's first baby died in the NICU. Her second baby has to go back to the NICU. What does the NICU look like to her? The NICU is the place where babies die. That's what she knows. Thankfully, that's not the case, as we know, but you want to talk about PTSD and going back to the NICU after her baby passed away in the NICU. So just trying to learn that, trying to put yourself in mom's previous situation. Coming back into the pediatric floor, coming into the PICU, if she's had a loss before, she's expecting the worst. Oh my God, my baby's in the hospital, or my child's in the PICU. This is terrible, right? That's what she's thinking. Outpatient. I love your question. Okay, so again, if you know already, that's good. But like Sharon was saying, if you see this big disconnect of, this is just like, this isn't that big of a deal. Why is this mom so anxious, so nervous? Or, you know, that her emotions are out of proportion to what is actually occurring. So maybe just probing, asking, do you have other children? How old are they? How many pregnancies did you have? Have you had a loss before? Because you sitting down and asking her that, she's going to know that you care. And then you're like, okay, I understand now why you're so upset or so anxious. Does that make sense? Great question. Thanks for that. Yes.
One thing we do in the NICU, which the PICU being a smaller physical space, may not be entirely an option, but if we know what pod that baby died in, we do not put that baby in that pod, the rainbow baby, in the pod during that next stay. We sometimes get heads up from our OB colleagues that we're expecting that baby. When we have twins who one dies early and the next one's going to be there a while, we actually will talk to the mom and say, do you prefer for this baby to stay in this physical location, or do you want to move because you never want to enter this particular room? They still have to go in the NICU, and entering those double doors is hard enough. But we want to try to do things, and so a lot of times we will have those conversations. If you had a primary nurse you really bonded with, and that nurse was there at your baby's death, do you want to have that nurse again because you really like that person? Or even though you really like that person, do you never want to see their face again? Mm-hmm. And different people are going to have different responses to that. So to some extent, we have those conversations. A lot of times, actually, it's our charge nurses will sit down and kind of talk to the families about, what do you prefer with this? And so it's not, they're still going to have this. They're still going to have, entering that NICU, that kind of PTSD, but we try to do things to minimize that and make it as comfortable as possible. And different people are going to have different responses, so talking with them. Plus, as Dr. Hayes said, that indicates you care, you're trying to address this.
And this is a question I was going to pose at the very end, but is this something we need to be putting in EPIC in the charts? And would we put it under family history? Would we put it under social history? I mean, I'm not sure. I think it needs to be there. I'm not sure where the best place to put it is. Do you guys have any ideas? Because if if the child that's coming into the PICU, if we already had a chart in EPIC for it, would you see, like, if it was in the social history, you know, I don't know if you want to put rainbow baby, but like mom had 2 losses or something like that.
Is there a code? I mean, there's an ICD-10 code for everything. Is there a code for death of sibling?
Oh, that's a good idea. I don't know, and I don't know that you'd want to put that on the problem list because.
But it is a problem.
Well, I've got a suggestion here.
I'd appreciate that suggestion because I remember a time not too long ago where I met with a child who I had seen before a few years prior and had not seen in between. And as I was going in with the resident who had gave me a great checkout and an update on the child's new problem, I said, well, this new problem, we need to think about family history. I said, are they, you know, I forget, does she have any brothers or sisters? Do they have any breathing problems? Well, we had lost her sister 2 years ago, a little bit before the time when I first met that child. And as my head exploded, and I wanted to crawl into the nearest hole in the wall I could find, I remembered we had that discussion. I said, you know, as I was thinking about it, I said, had I looked at the history, I probably could have picked that up. But when you don't hit that little down arrow in EPIC and you addressing your problem, you know, and after that moment that she said that, I remember our conversation when we first met about the loss of her other child. But in between, I forgot, and I probably triggered an event for her.
Well, exactly, because, I mean, we can't remember everything, right? So, I don't know, just something to think about it, and I'm not sure where the best place to put it in the chart is. So just an idea. I'm going to try to finish up real fast. In the outpatient setting, so if you're the PCP, this mom maybe had a loss for her first pregnancy, got a rainbow baby, nice term, healthy baby. She's going to have lots of questions. She's, again, going to be anxious. She might come in for every little sniffle, every little thing that's wrong with this baby. Like, why is this mom coming in all the time? This baby's fine. So just knowing that. Also, these moms are at higher risk for postpartum depression. I know in some of our clinics we are doing a postpartum depression screen on all of our moms. So, and I think that's great. I think that's necessary. And then each exciting milestone, holiday, may be a trigger for this mom. So, yay, baby's 1 year old. We got our 1 year well child check. Or the holidays are coming up. She might not be as excited. She's excited that her baby's now 1 year old, but she's also thinking about, well, my other baby would be 2. So just thinking about that. I do want to talk about siblings because the siblings are also going to be our patients. A lot of times we think of the loss was maybe mom's first pregnancy, but that's not always the case. We could have 2 siblings that are our patients, you know, a 5-year-old, a 7-year-old, and then mom has a loss. So how are the siblings incorporated into that? Because they're our patients, right? Were the other children included in the baby's decisions? Like, were they involved in the rituals, in the memorials? Did they have a part to play in the funeral? As the parents are going through the grief, the children, the other siblings, they're upset, obviously. They can feel that the parents, you know, aren't doing well. So it's not unusual for the children to feel somehow responsible for the loss. Did I do something wrong? You know, I was really bad that day, you know, something like that. And then children often cannot or do not know how to talk about grief, so they might act out instead. They might start misbehaving at school or doing things abnormal for them. And then they could start having new physical symptoms, so coming in for a sick visit or exacerbation of already pre-existing physical or mental problems that they have. So the one I think of is irritable bowel syndrome, IBS. If a kid already has that diagnosis and there's been a loss in the family, expect to see an exacerbation. And then do the siblings need to be to see a grief counselor or in a sibling support group, which we do have here in Roanoke. But then anything that is beyond like a normal grieving pattern, you would want to assess for and treat for depression. Remember that they will always love and miss their sibling, even if they never got the chance to meet the baby. Grandparents are often the forgotten grievers. They have a double grief going on. Their grandchild has died, but then their child is hurting because of the loss. So they've got two griefs going on. I'm going to try to go through, let me go here. So here's local resources for these families, and then I'll be done. Our Carilion share group. Please contact Sharon or me if you know or come across anyone that could benefit from our share group. Compassionate Friends is a support group for people who have lost children. March of Dimes also has a lot of perinatal and infant loss resources. Molly's Bears is a resource, non-for-profit, that actually will make a bear, like that picture there, and puts weights in the teddy bear for however much the baby weighed, baby that died weighed. So this is really good for like siblings, you know, like toddler and younger age, because they have this tangible thing they can play with and hug and hold. Carilion Clinic Soul Survivors, that's the one for siblings. And then Sid the Lion, another one. This month, at the end of this month, is the annual Remembrance for Carilion Children, a butterfly release. Last year it was absolutely beautiful. We're doing that again. And then in October, we have our Share Walk. We do this every year. So it's October 14th, Green Hill Park in Salem. So I'm sure, like on the Carilion page, this will be advertised as we get closer. So we do this Remember Walk every year. So I think we've talked about all this, but just to wrap it up, trying to sympathize with the mom or the other children. What was the previous loss scenario? Trying to put yourself in their shoes. Then reading mom's cues, doing the postpartum depression screening. Expect unresolved grief. You saw those diagrams, lasted for 2 years, spiked at different parts. And within those 2 years, mom probably has had another baby that we're going to be the caretaker for. Keep the instructions simple. So say there are just minor problems with this rainbow baby, don't give her this whole laundry list because she's still working through her past grief. So keeping your directions simple and straightforward. Remind mom to be patient with herself. And again, let's think about where we should put this in ethics so that everyone's aware. And I'm done.